and welcome to Dragon Bytes, the paediatric podcast aimed at paediatric trainees or anyone interested in child health. I'm Stacey Harris, one of the founders of Dragon Bytes and a paediatric trainee here in Wales. This week we have another revision podcast. It's from Dr Graham Shortland, a paediatric metabolic disease consultant, and Dr Assim Javaid, the other founder of Dragon Bytes. They discuss together metabolic disease and intellectual disability. Let's get started.
Welcome again, everyone. I'm Assim Javaid, one of the presenters of Dragon Bytes podcast. And yet again, I'm joined by the absolutely fantastic Dr Graham Shortland, who's going to be giving us some more teaching on inherited metabolic diseases. So I think the plan for today, Dr Shortland, was to discuss intellectual disability.
Yes, I think that this is perhaps a problem that faces many trainees, faces many consultants, faces us all, in terms of children who present with intellectual disability, and what is the nature of the investigation that we should be doing. And like the other presentations that I've given, this is really giving you food for thought. There are a huge range of disorders that we may need to consider, but this will give you food for thought around patients presenting with intellectual disability.
So just getting into it, I mean, are there any specific points or highlights that we need to consider quite early when we're thinking of patients presenting with intellectual disabilities?
I think it's really important that, and again, none of us will get this right all of the time, but clearly we are not going to be investigating every child we see with some degree of developmental delay. And we'll talk about some indicators later on in the podcast. But that clearly, I think, with isolated speech delay, I think that in children with mild or moderate isolated psychomotor delay, that one has to consider carefully whether you would launch into investigation for those patients. Certainly, I think that red flags where one would look very hard in terms of widening the investigation net would be in those patients that have static developmental delay, those that have severe developmental delay, and the one that really stands out is the patient that has developmental regression. That perhaps the example par excellence of developmental regression is the presentation of the patient with Sanfilippo syndrome. And that's an autosomal recessive condition, so that may not have presented in the family before. Sadly, we don't have treatment for that disorder, but in terms of giving the family advice around future children, it is important to make that diagnosis. And these children may appear normal in the first few years. They then present as very hyperactive children. They may have significant diarrhea and disturbance of their bowel habit, and they gradually lose skills. Particular of note, they may have acquired speech skills, which they then begin to lose. And this group of patients, whilst they, I think, contrary to the textbooks, they do actually have some symptoms they do have signs of coarsening of features that may not be that marked. So it may not be noted, and so in those patients, static development or developmental regression, particularly with speech, is going to be the marker that says we really need to investigate this patient fully. Yeah,
I know this is a brief aside, but Sanfilippo, I can recall that from my examination, but for the life of me, I can't remember what actually has gone wrong from a metabolic perspective.
So Sanfilippo is a mucopolysaccharidosis. It is one of the lysosomal disorders. It's a mucopolysaccharidosis, a storage disorder. It's MPS type 3, and I think that in terms of the important thing is the analysis of the urinary gags, the glycosaminoglycans, to seek that urgently. Again, if you've got a high clinical suspicion, you need to further discuss that with the lab, because sometimes in that type of mucopolysaccharidosis, and also perhaps in some other types, you don't always see an abnormality, and you may need to go on and do further enzyme studies. But certainly the urgent test would be to do a glycosaminoglycans, because these patients, sadly, there is no treatment for them, and they may then die in their teens or early 20s. But once again, the important thing for the family will to be informed of the diagnosis, so they have the ability to decide whether they want future family, and we can offer advice during a future pregnancy.
Sure. Thank you for clearing that up, just for my own sake.
Yeah.
So I was thinking back of what you said. I know we've mentioned a few red flags here, but thinking about the fact that particularly in community paediatrics, intellectual disability is probably very common, as is a degree of developmental delay. So, I mean, in this sort of realm, where do we draw the line between those we investigate and those we don't?
I think that clearly from a history, again, we're going to have the possibility of a sibling who may be undiagnosed, and that would be important in terms of recognising again that one would wish to raise the ante in terms of investigation of children where there may be two children with similar presentations. Again, most of the conditions are autosomal recessive. Some of the mucopolysaccharidoses are not, but again, I think where there's a strong family history of a similar problem, I think that, as I already hinted at, isolated developmental delay is unlikely to result in a positive investigation for other causes. It's where one has a number of different factors that are coming together, and I think that where you have a history of, for example, developmental delay plus hypertonia, where you might have developmental delay plus any other system really, where one's talking about cardiomyopathy, one's talking about liver disease, one's talking about dermatology, eczema. I mean, I suppose from a condition point of view, the presentation of developmental delay with eczema and perhaps some degree of metabolic acidosis might suggest biotinidase deficiency to you. And biotinidase deficiency is one that we don't want to miss. This can present during the neonatal period, and that I think that a simple blood test, and then this is probably one of the most satisfying conditions to treat. The use of biotin can actually transform children with significant developmental delay to children who then subsequently develop normally. So again, it's not just the developmental delay, it's a history of perhaps abnormal breathing, which is suggestive of the metabolic acidosis, with the eczema. It is the key to the underlying diagnosis of the developmental problems or the intellectual disability.
Another question, yet again, my own curiosity jumping in. So with the example of biotinidase, if you can treat it, do these children then get a degree of developmental catch-up, or is the damage that's been done always present?
We have seen a number of children where we have seen significant catch up with developmental delay. You're right that in a number of the conditions we see where we may be able to institute treatment, that we are actually trying to hold the disease. But certainly biotinidase deficiency, that's why it's so satisfying. The use of biotin can result in children with significant developmental delay then developing normally, and we've had a number of cases where that has been the case, hence the need to consider that as a diagnosis.
Oh, brilliant, thank you. So we discussed a few elements from the history there that are key. Was there anything else from the history that would help?
I suppose that other examples would be the presentation of, and we're moving between history and examination really,
sure.
is the presence of other dysmorphic features, and I think that as well could prompt more obvious investigation. So family history, some metabolic disorders may present at birth, and I think some of the peroxisomal disorders like Zellweger's, some of the congenital disorders of glycosylation, which can present with a varying number of symptoms, and again I think any history of a child presenting in the neonatal period with a constellation of symptoms, one should be considering screening them for congenital disorders of glycosylation. Lysosomal disorders will come on in a minute in terms of presentation of physical presentation. Smith-Lemli-Opitz is a metabolic disorder that can present in the neonatal period with microcephaly, with the unusual faces. And again, the mitochondrial disorders. We talked about a lot of acute presentations last time. Mitochondrial disorders, which result in intellectual disability, can present very rapidly, perhaps not after 2 or 3 days. So I think the number of the disorders with intellectual disability may present already at birth with signs and symptoms. That's different to some of the acute metabolic disorders like fatty acid oxidation, urea cycle disorders that we said require that 1 to 2 days, that first 48 hours, when they've lost the placental protection.
That's really interesting. Was there anything else from physical examination? Is it largely looking
Yeah,
at
so I think this is where we get into a really important area. So you've got your child, you have your child with intellectual disability, you perhaps are seeing quite severe intellectual disability, severe developmental delay. What are the aspects of the examination that give you further clues as to where you do investigate? And I suppose if we start sort of head down, there's general dysmorphic features. And I think it is really important to consider jointly investigating these patients with the geneticist, where you've sometimes got features that you don't recognise or you're not sure. Let's get a geneticist and let's see what they think of those features. So, and again, these features are sometimes difficult. Coarsening of features in the classic mucopolysaccharidoses, such as with perhaps a Hurler-Shea patient, can be difficult. I've seen a number of mild Hurler-Shea, i.e. at the Shea end of the syndrome, that have taken a long time to diagnose. When I see them, it's very obvious that they have coarse features, and they might have presented with the joint abnormalities and some degree of intellectual disability. So dysmorphic features, just looking, I think the geneticist called it gestalt. You just look at the child and you suddenly get what's wrong with them. So dysmorphic features, coarsening of features. Hydrocephalus, again, mucopolysaccharidoses, Hurler-Shea, Hunter syndrome, you can present with hydrocephalus in those conditions. Coming down in terms of cardiomyopathy with any really metabolic condition is important, and also hepatosplenomegaly. Hepatosplenomegaly, again, in presentation of lysosomal disorders, and looking for that abnormality. One other specialist that I find very useful is also where you think there may be an underlying metabolic condition is the use of the ophthalmology services. So making sure that you have a proper look at the eyes. Now, I'm sure you as a paediatrician are very good. I'm not so good, but you can sometimes see cherry red spots present. I've diagnosed patients with cherry red spots and sent them to the ophthalmologist. Corneal clouding can present. We can see cataracts in some of the problems. So it is really important as part of your full assessment of physical abnormalities to actually get an ophthalmology assessment. What I've not mentioned is probably joints, and sometimes you can see characteristic, perhaps claw hand, again, of mucopolysaccharidoses, and abnormal posture in terms of the examination. Inverted nipples of the congenital dislocations, disorders of glycosylation present like that, and general disorders of tone, which may require a joint consideration with the neurologist, and what sort of pattern of abnormality of tone is this. So those are some of the things that I would look for in terms of extending the metabolic investigation. I suppose the other thing is the general behaviour of the child. I would include significant behavioural problems as perhaps sometimes being related to presentation of metabolic disorders. I think that once again, these can present in so many different ways, but that's a starter for 10 in terms of the sort of investigations, the sort of reasons that one would then go on and do further investigations.
That's really helpful. Thank you. I was just thinking briefly about what you mentioned about the sort of like Gestalt thinking around a lot of these things, because certainly for our junior colleagues, the very subtle end of dysmorphic features are often difficult to pick up. So I suppose there's a point for the juniors to get someone more experienced to review your patients if you are thinking along these lines, and perhaps to have a low threshold to get a senior opinion if you're thinking someone has subtle signs of dysmorphic features.
I think so, and we all know, don't we, as trainees, explaining that they're doing that initial disclosure. I mean, the one par excellence is the initial disclosure to a parent that their child might have Down syndrome.
Yeah.
We're being a bit more subtle now, using those terminologies. Well, yeah, does he look like his parents? And there are various different ways to do this, which I'm afraid you just have to learn by watching other people that are good at doing it. But there is something around senior colleagues. For example, Angelman syndrome. A number of us have seen that, and we know what that looks like. Senior colleagues looking as well as our genetic colleagues looking. And as I say, I think sometimes the other thing is the ophthalmologist. The one I potentially missed there was the severe short-sightedness with developmental delay and the abnormal, in terms of their size and their height, with homocystinuria. We would hope not to see that as much now, because we've started in the last few years to screen for homocystinuria, but there'd probably be a lot of unscreened children out there. Well, not a lot, but a number of patients out there with homocystinuria. And certainly, again, the reason for looking at the eyes is that if you see a child with severe myopia, think about screening them for homocystinuria with their plasma amino acids and sometimes urine amino acids, although I must admit that urine amino acids are not used as much as we previously did.
So while we're on the subject of testing, during our last podcast we did a lot of discussion around what tests we need to do for the acutely unwell child.
Yep.
Are there any tests we should be considering in a child who's otherwise well, but we might be thinking about an underlying metabolic condition alongside all of those that we've discussed previously?
So I think that we come back to, so we've got a child, we have our child with intellectual disability, we have our child who perhaps has some mild dysmorphic features, and you think has slight coarsening of features, but you're not sure. Don't forget the consideration again of other general metabolic conditions. I mean, delayed development and thyroid function. Every child should have their thyroid function as part of neonatal screening. However, there are other causes that may not be picked up by screening, and also children that come in from other countries. So you don't want to miss hypothyroidism with developmental delay. So make sure that's done. I think also we can consider a number of these disorders are going to be underlying genetic disorders, and we know that we're doing DNA array testing, Fragile X testing, and I think I did touch upon in the last podcast the use of the whole genome sequencing. We are moving into a new era which juniors such as yourself and other more junior colleagues, in 10 years' time, then you will be using whole genome sequencing in a whole range of situations, including intellectual disability and including the sick presenting child in PICU, and also the sick presenting neonate. And whole genome sequencing is likely to be the way forward to more rapidly diagnose rare disorders. That is not to say that we should use other metabolic biochemical testing to actually get to the bottom of these disorders. So creatinine kinase, I think, is an important one in terms of looking, have we got muscle involvement? And is that muscle involvement part of mitochondrial disorder? The lactate, plasma lactate, is very crude for the diagnosis of mitochondrial disorders, but nevertheless a significantly raised lactate with a CK would be important with intellectual disability, perhaps in terms of diagnosis of a mitochondrial disorder. I think that you will have done the routine biochemistry in terms of renal function, liver function, and also your bone function. I think that's important, just to look for any indicators there. But what you're then doing is moving on really in terms of more specific metabolic testing. And I think that it would be important to, certainly urinary glycosaminoglycans for underlying MPS and stroke lysosomal disorders. They will usually also do the urinary oligosaccharides, again for those underlying disorders. I think urine organic acids are important. We picked up a number of milder methylmalonic acidemia patients and others through urine organic acids. Generally, the laboratory here doesn't favour using urine amino acids, and are very confident if we make sure we use plasma amino acids. We had recently, a little while ago, a patient with developmental delay, but again, the clue was it wasn't just isolated developmental delay, it was significant gait disturbance and other abnormalities in neurological tone. And that child was picked up on plasma amino acids, which I think are important to do, as having an arginase deficiency, which is very rare. And we also then screened the other sibling, and unfortunately the other sibling also had it. So plasma amino acids are important. I think plasma acyl carnitines are important in terms of, again, underlying diagnosis, and that would help with, again, MMA and some other disorders. Glutaric aciduria type 1 sometimes can present with the urine organic acids. That probably is another presentation that increasingly trainees are going to come across, and that's the child with macrocephaly, and the child who may have had evidence of frontal lobe intercerebral bleeds, and the increasing awareness, certainly in children with undergoing safeguarding procedures, of the fact that glutaric aciduria type 1 can present without abnormalities. You can get non-excretors without abnormalities in the urine organic acids or abnormalities within acyl carnitines. So we have had a number of patients that, just to be absolutely sure, where we have had to perform skin biopsy and look at the enzymology to exclude glutaric aciduria type 1, because that can be confused with frontal lobe bleeding, development of macrocephaly, and clearly the child who may have actually had physical abuse as opposed to having an underlying metabolic disorder. Some protocols mention lead as a cause for intellectual disability, but I don't think in Cardiff we've got much lead around. But I think if you're in North England or Scotland or something like that, you may also find lead present. Very long chain fatty acids also would be important, and I think that's not an unreasonable first screen, again depending upon what the physical abnormalities are that you find in discussion with your neurologist, your geneticist, and your specialist metabolic clinician. One last thing, I think in terms of where we get to, is it's rather like it's the same scenario in this group of patients as the patient who sadly doesn't make it in the acute phase. There are going to be patients where I think that we still don't make a diagnosis, and I think for me, in terms of deciding how much further, because any doctor, however clever or however daft they are, can always do another test. Will that test in all probability result in a positive result? And we as paediatricians are acutely aware of the fact that doing a blood test is a difficult thing for a child. If we need to do it, we need to do it. But I think that's important. And I suppose the other thing would be, the one I didn't mention was the use of MRI and MRI spectroscopy. I think that's important, and sometimes EEG can give us important abnormalities. So other ways of screening children through neuroimaging are very important. But so there may be times, however, when we don't make the diagnosis, and I think then that means that you take all reasonable steps with your neurologist and your geneticist and your metabolic doctor. That, I think, is going to change with us using more frequently whole genome sequencing. But sometimes you come to an agreement, you come to a contract with the family that they don't wish to have any further investigation, and that there is a point where we would assist that child in optimizing its development with speech therapy, with physiotherapy, with many other things, but particularly where perhaps the family have reached the point where they don't want further children, and where there is not, that they may decide that that is enough investigation. That is not to say that, again, and I think, once again, repeating around whole genome sequencing, there are possibly many patients I've seen over my career that 4 or 5 years ago one might have said, okay, we've done enough, let's just wait and see, but where we might be reconsidering investigating them again. That is not to say that whole genome sequencing does not come with its own problems, and many of your juniors will already be aware of patients who have reports where sometimes the mutation is of unknown significance. And I've had patients very recently with peroxisomal disorders where there is an unknown mutation, and the question is that this child is only mildly affected. Are you going to tell the parents that that child is affected with a peroxisomal disorder, or is it completely unrelated, and is it a mutation of unknown significance? So lots of challenges ahead with whole genome sequencing, but I think there is the child in whom sometimes we say, stop, we've done enough investigation, the family do not wish to have any further information with regard to their future risk in future pregnancies because they're not going to have any more children, and who perhaps we say, okay, let's come back, and the geneticists are probably better at this than us, who say, come back in 2 or 3 years' time and we'll think again about where we go. So you will sometimes reach the end of this diagnostic trail, and you may, with the parents, say, let's stop, we've done enough, and then let's just wait and see.
Lovely. Thank you very much again, Dr. Shortland. That's been very enlightening. So, quick key messages to take home.
Key messages are that isolated speech delay and isolated mild to moderate psychomotor delay probably not got an underlying metabolic disorder. If, however, both in terms of the history with other family members or on physical examination with perhaps dysmorphic features with involvement of another system, particularly neurological systems, then I think you would be looking to further investigate. Certainly in the child that presents with static development, or the child that presents with regression in development, you must throw the book at them in terms of investigation. Always consider further engagement, certainly obviously with your, as far as the trainees are concerned, with your senior boss in terms of getting advice. Have they seen that child, that type of presentation before? And I would also do not infrequently advise my other consultant paediatrician colleagues that refer to me, consider the geneticist and consider the neurologist. Because they may be able to assist you in making the diagnosis and advising further investigations, both genetic and perhaps in particular neuroimaging.
Lovely. Thank you again, Dr. Shortland.
Thank you.
Bye.
Thank you both again for another brilliant podcast. Just to go over what was discussed. They discussed when to further investigate intellectual disability, the red flag signs to look out for, some of the points in the history to look out for, and the signs on examination, the signs associated with various metabolic diseases, and the use of the MDT meeting, for example, ophthalmology, neurology, and geneticists. Also, the tests to consider undertaking in the investigation of intellectual disability. Thanks again. Join us next week when we have the abdominal examination pub quiz. Don't forget to subscribe to our podcast, let others know about us, find us on Twitter, dragon_bytes, and check out our website, www.dragonbytespodcast.com.